Hello everyone, and thank you for joining me today. My name is Jesse Smart, and I'm a doctoral student here at Maryville University. I've been an EDRN for about 6 years now. I have a master's degree in nursing education, and while finalizing my DNP requirements, I'm simultaneously obtaining my NP in acute care nurse practitioner. Today, I will be presenting to you my DNP scholarly project, which entails and is titled Implementing a Sepsis Response Checklist in the Emergency Department. This will be a virtual introduction in this DNP projects committee. First, we have my DNP chairperson, Dr. Tanya Crystal. She has been closely working with me to keep me on the right track and allowing for a structured approach with a cohesive presentation on my project and its findings. My second reader is the Assistant Chief Nursing Officer, the ACNO of CHA Everett Hospital, where this project took place, Janine Runquist. Janine is also on the CHA IRB team and was very helpful throughout the IRB application process. The community members for this project is my best friend, Greer Shute. Greer is a fellow EDRN with a passion in providing quality care and has a great understanding of the importance of having protocols in place and the potential benefits that can occur from them. Okay, let's get started. I want you to think to yourselves, who here works in acute care? Do you work in the emergency department, a medical surgical unit, or even the ICU? Who here has seen the detrimental effects of not having a system in place or a protocol, if you will, whether it be one of your patients or even a loved one? We're going to talk about sepsis. What is it? What's happening in the system? What needs to be done? Sepsis and septic shock resulting in multi-organ failure are the current leading causes of death in adult critical care units. Centers for Disease Control and Prevention states about 1.7 million Americans become septic each year. That results in nearly 270,000 deaths. That's very significant. Epidemiological studies are showing that there's an increased incidence of sepsis over the last 20 years, despite continuous improvements and advancements in these surgical and pharmacological approaches to sepsis therapy. The healthcare system routinely is failing to comply with the implementation of evidence-based strategies to ensure sufficient care to this patient population. Quality initiatives must be implemented within the emergency department to enhance compliance with evidence-based strategies for septic patients to achieve greater positive outcomes. There was no sepsis response protocol in place at this small community ED in which this project took place. Now we're going to talk about the purpose of my project was to decrease the number of inappropriate admissions from the emergency department to another unit, whether it be medical, surgical, or ICU. And this is to ensure ongoing efficient monitoring and management of patients presenting to the ED with sepsis. The Sepsis Scholarly Project is a quality improvement initiative. It aims to compare the effectiveness of a sepsis response protocol for improving the staff compliance to a sepsis response checklist, which I'm hoping to yield greater positive outcomes. Specifically, the goal is to achieve above 85% compliance with providing evidence-based strategies as outlined in the implemented sepsis response protocol. The protocol includes all septic patients receiving 30 milliliters per kilogram IV fluids within the first hour of identification of sepsis. It's anticipated greater than or equal to 85% of ED staff utilize the implemented standardized sepsis response checklist when providing care to this population. Another goal for this project is to yield at least an 85% decrease in unit changes to the post-intervention group. The specific question of inquiry is, in adult patients presenting to the emergency department with sepsis, does the implementation and use of a sepsis response protocol, when compared to not implementing a sepsis response protocol, lead to decreased change in unit within 72 hours of admission from the emergency department? Now we're going to be going over the sepsis response checklist next. I'll give you an overview of what that looks like. Let's talk a little bit about the background to this project. So nurses take on many roles. So they can be an educator, an advocate, and change agent. We've taken on these roles throughout a day, but they always maintain a common goal, and that's to provide safe, quality care. This project, it promotes opportunities for nurses to take on these various roles and most importantly, practice with autonomy. With nurses often being the patient's first point of contact, they must ensure quality care through prompt and effective critical thinking skills. Regarding healthcare, the purpose of this project is to address a phenomenon or problem of interest in the healthcare system which is supported by evidence. The project addresses the need for greater compliance with evidence-based interventions for septic patients by implementing a sepsis response protocol. The Quality Improvement Initiative appeals to stakeholders and is generalizable enough to be systematically implemented across various healthcare organizations. This project aims to close the gaps between desired and actual patient safety and quality outcomes related to sepsis. The Advanced Practicing Registered Nurse, or APRN, constantly and efficiently evaluates the patient's dynamic condition and reactions to the interventions, and continuously adapts the patient's management plan to fit the patient's specific needs. This project prompts the nurse to respond quickly to the patient in the acute care setting presenting with sepsis and start interventions supported by evidence. The APRN uses this project alongside others similar in similar contexts to help close those gaps again between that desired and actual patient outcomes, but for all patients. Current literature suggests that a sepsis response protocol contributes to greater positive patient outcomes. A review of current literature yields three main themes that contribute to the success of implementation and sustainability of a sepsis response protocol: the effects of compliance to sepsis response protocols, early treatment of sepsis and their associated outcomes, and the effects of sepsis response protocols on the length of stay and patient acuity. The first theme identified in the literature is staff's compliance with a sepsis response protocol and its associated outcomes. Compliance to a sepsis response protocol decreases mortality rates, hospital readmission rates, and inappropriate admission to the ICU. The second theme identified in the literature is early treatment upon recognition and diagnosis of sepsis and its associated outcomes. Time-sensitive interventions, which is your fluid resuscitation, antibiotic administration, etc., dictate outcomes in septic patients. Delayed fluid resuscitation directly contributes to mortality and increased ICU admissions. The third theme identified in the literature is the ED length of stay, or EDLOS, and the acuity level chosen for each patient. Increased EDLOS is linked to more ICU admissions, which could be avoidable with a combination of the identified themes: compliance and early treatment. Longer EDLOS requires more resources and increases the risk of the patient needing mechanical ventilation, which would lead to more avoidable ICU admissions. EDLOS time can be decreased through compliance to a sepsis response protocol with specific guidelines for interventions. This DNP project utilizes theoretical frameworks to serve as the foundation that supports the successful implementation of a sepsis response protocol. The theory of planned behavior, TPB, consists of the following propositions: that behavior that is volitional is determined by people's intentions to perform that behavior. Intention to perform or not perform a behavior is determined by three factors: attitudes toward the behavior, subjective norms, and perceived behavioral control. The relative importance of the three factors in influencing intention varies across behaviors and situations. People are more successful in committing to positive behaviors when they are allowed to do so willingly and have available resources. So we're talking time, money, skills, cooperation from others. Successfully achieving desired positive behaviors depends on the motivation or intention and the ability, behavioral control, to commit to those behaviors. In using this theoretical framework, I was able to first establish my staff's baseline perceptions on the current issue and create an approach that was receptive to those perceptions. Did they see that there was a problem? Did they understand the potential benefits from implementing this protocol? Most importantly, were they going to support this change, possibly change their behaviors, and commit to more positive working behaviors proven in the literature to yield greater positive patient outcomes? Here's the sepsis response checklist that was deployed. I drew inspiration for this from a previous hospital that I had worked at that showcased its success. Nurses have care and management protocols in place for various situations. However, this organization did not have a official sepsis response protocol in place. What this sepsis response checklist does is it ensures that nurses are releasing the sepsis order panel that is already in the system, and care should begin immediately at that point. You can see that the patient would be assigned the highest acuity level, the level 1. The remaining evidence-based interventions are seen here in the checklist as well. Some important interventions that I'm going to point out are the ones that pertain to my checklist. So this is your initial lactate level, your initiating of the fluids, and a repeat lactate level after those fluids. The checklist was available to all RNs in the emergency department, and I collected this weekly from the ED nurse educator who kept it safely stored. Let's talk about the methods used for this project. A quantitative, exploratory design through retrospective chart review was most appropriate for this project because it allowed for the implementation of an intervention and the review of the data to draw conclusions about the effectiveness of the intervention, which was the protocol. The project included no patient identifiers and participant privacy was ensured. The study period began January 1st of this year through May 2nd, and analysis of the data began shortly thereafter. Data was collected from the EMRs and transcribed into a data collection sheet, which we will be going over shortly. Data analysis was conducted through a z-test for the difference between two proportions, which again we'll review in a moment as well. Regarding the sample, the data for this project is extracted from the EMRs, which included patients between the ages of 18 to 89 years old, presenting to the hospital with sepsis. Had anticipated 20 participants meeting criteria for both the pre and post implementation groups, being 20 for pre, 20 for post. This hospital is a small community hospital that treats on average 5 to 6 septic patients a month. That's not a lot when we're comparing it to our larger scale, higher trauma level hospitals. The data abstracted from these EMRs from the participants had to have a diagnosis of sepsis and were treated and dispositioned from the emergency department, where they were either transferred to the medical surgical unit or the ICU or had expired, but there were no included participants that had expired during this project. The pre-implementation group was from January 1st through March 1st of this year, and the post-implementation group was once the checklist was deployed on March 2nd right through May 2nd. Let's talk specifically about the sample population from this organization. Descriptive statistics were used to assess the demographic data of both the pre and post sepsis response intervention group. Figure 1 here is showing you how both the pre and post intervention samples happen to consist of 50% female, so your number is 20, and 50% male, your number is 20 for participants. Figure 2 here below is showing the ethnic background of the pre-implementation sample, which included Brazilian. This is a very high Brazilian population area. Brazilian was at 50%, so that's 10 out of the 20. Hispanic was at 15%, so we had 3 out of that 20. Caucasians was 15%, Haitians at 10%, and then other being 10%, where there was only 2 out of the 20. The ethnic group background of the post-implementation sample was rather similar. So Brazilians were at 45%, this was 9 out of the 20. Hispanics at 20%, where it was 4 out of 20, and then Caucasians at 20% as well. Haitian was at 5%, and then your other was 10%. We can see that there was no significant difference between the pre and post group here. Yes, there's a slight difference with our numbers, but nothing significant, no outlier data. Another important descriptor to this sample is the patient acuity level that was assigned at triage, as shown here in figure 3. 1 is your high risk. This is your septic patients. 2 is complex. 3 is moderate risk. 4 is stable. Pre-implementation acuity levels were as follow. High risk being 25%. That was only 5 of the 20
That's saying that the septic patient was only given an acuity of 1, 5 out of 20 times. Complex was at 60%, that was only 12. Moderate risk was 15%. And stable, nobody put them as stable. Very good. Remember, sepsis should always be considered high risk. High risk acuity level post sepsis response checklist implementation was assigned 100%. That's number is 20. So 20 out of 20 of the sample. The nurses displayed a great deal of compliance in using this sepsis response checklist, and it is evident that they had a greater understanding of the importance of assigning these patients as high risk. This is a representation of the data collection sheet. There was one used for the 20 participants of the pre-implementation group and one was used for the post-implementation group. It tracks data such as sex, age, if the order panel was released by the RN, the acuity level assigned to the patient. Remember, sepsis is a life-threatening illness and should be assigned at the acuity of a level 1. Baseline lactate level with fluid resuscitation, was that completed? If the repeat lactic level had improved, this is just a simple yes or no, which unit the patient was admitted to, because then we're going to assess whether there was a unit change had occurred within the 72 hours of admission from the emergency department. Let's talk about data analysis. The data collected to evaluate the trend in unit change within 72 hours of admission from the ED was analyzed using the z-test for the difference between two proportions, with a level of significance of 0.05. This test allows you to compare two proportions to see if they are the same. The null hypothesis for the test is that the proportions are the same. The alternate hypothesis is that the proportions are not the same. The lower tail z-test for the difference between two proportions test was used to determine if there was a statistically significant difference between pre and post intervention implementation data, specifically a unit change occurring within 72 hours of admission. A confidence interval was calculated using a confidence level of 95%. All right. Let's get to the part we were all waiting for, the results. What were they? Statistical analysis software SPSS was used to conduct the z-test for the difference between two proportions. The first section, titled Data, shows pre and post intervention findings. Here we can already see significant findings. In the post-intervention group, there was only 3 out of the 20, that's 15%, of unit changes. In the pre-implementation group, there was 9 out of that 20, that's 45% unit changes. That's just over a 66% reduction in unit changes. That's insane. We were hoping for the 85%, we didn't get there, but this is a great improvement and it's saying a lot for what we've done. The next section, intermediate calculations, has calculated the proportions between these two groups, identified a difference in the population, and generated a z-test statistic. The last part of the table, titled Lower Tail Test, shows the calculated p-value, which is used to reject or accept the null hypothesis. This might just be a bunch of word jumble, but septic patients who were treated in the ED after implementation of a sepsis response checklist had statistically significantly less unit changes within 72 hours of admission than septic patients who were treated in the ED before the sepsis response checklist was implemented, as evidenced by our z equaling negative 2.0702. These numbers have value to them. And then our p-value, that power, was 0.0192. Tests for the difference between two proportions revealed that the sepsis response checklist intervention implemented in the ED proved effective for prompt and adequate septic symptom management provided to these septic patients presenting to the ED when compared with patients treated for sepsis before the intervention was implemented. This is fantastic findings. Limitations to this project pertain to a lack of previous research studies on the topic, limited sample size, and time constraints. With the project taking place in a small community hospital that's not considered a trauma center, it was difficult to even get 20 participants that were desired. In a smaller sample size, the reliability of the results becomes questionable. But in this case, the results are true to the organizations, which suggests the need for a sustainable protocol. The time constraints led the project to have a smaller sample size as to complete the tasks and finalize the results by the academic organization's due dates. The COVID-19 pandemic still had surges during that time of the project that took place, further limiting availability of administrative resources. The project was limited to adults aged 18 to 89 years old, which restricts the ability of generalizability of the results. There is a good generalizability of the results beyond the age restriction. The project looked at the effect that a sepsis response intervention had on disposition of the septic patient. Patients initially seeking care when critically ill had been seen, treated, and dispositioned from the ED. As such, these results can be applied to other organizations across the country. The overall approach to caring for septic patients can be applied across all healthcare organizations because the project's results prove that the intervention led to greater positive patient outcomes.
I'm going to talk about the results as it relates to impact. The project aimed to enhance the quality of care that is provided to septic patients presenting to the ED by ensuring timely and efficient care that affects morbidity and mortality. Nurses, physicians' assistants, and physicians were all educated on the importance of prompt implementation of evidence-based interventions as outlined in the sepsis response checklist. They understood that once the sepsis response checklist was deployed, the nurses were able to release the sepsis response order panel and perform the tasks outlined in the checklist once sepsis was identified. The project found that staff education led to 100% compliance with implementing the sepsis response checklist. The interventions conducted through the use of the checklist led to a significant decrease in the change in unit within 72 hours of admission. Such findings suggest that compliance to a sepsis response bundle promotes prompt and sufficient care for such critical patients. Furthermore, the results show the benefits of having policies, procedures, or protocols in place that support the autonomous role of the nursing staff. It's important to highlight the implications drawn from this project, implications for nursing practice and future research. This project deployed a protocol that prompted the ED nurse to release the sepsis panel order set and begin interventions immediately upon identification of sepsis. The project found that this approach led to a significant decrease in unit changes within 72 hours of admission from the ED. Future practice and research can be further enhanced through conducting root case analysis, or RCA, to identify causes of problems, barriers, or events and respond to them effectively. We want to ensure that this patient population gets the most efficient care. They're very critical patients. When the healthcare organization understands the importance of conducting a barrier and change analysis and implement corrective action, they have more opportunity to yield greater positive outcomes for this vulnerable population. The study supports the notion that a sepsis response protocol leads to greater positive outcomes for septic patients presenting to the ED. The study had a smaller sample size due to time constraints and the COVID-19 pandemic, but based on the data that was collected, the results show a statistically significant improvement in appropriately dispositioning the patient from the ED to another unit, whether it's the medical surgical unit or the ICU. To further improve the quality of care for septic patients presenting to the ED, the following strategies must be addressed. Number one, we have to improve staff education on the identification of sepsis. We have to, number two, implement an official sepsis response protocol. 3, promote greater interprofessional communication and collaboration across all healthcare settings within the organization. With regard to this organization specifically, I recommend that if an official sepsis response protocol is not put into place, they should at least continue to utilize this sepsis response checklist that has proven to yield greater positive outcomes for septic patients presenting to this emergency department. Okay, now in conclusion, the use of a sepsis response protocol in the ED led to a significant decrease in unanticipated unit changes within 72 hours of admission from the ED. After implementation of the intervention, the results showed a decrease from 45% to 15% of the group with a unit change within 72 hours of admission. Previous studies found that the use of a sepsis response protocol decreases in hospital mortality, length of stay, and healthcare costs through the provision of prompt evidence-based interventions. The project supports the notion that a sepsis response protocol leads to greater positive patient outcomes for septic patients presenting to the ED. The project had a smaller sample size due to time constraints and the COVID-19 pandemic, but based on the data that was collected, the results show a statistically significant improvement in appropriately dispositioning the patient from the ED to another unit, your med-surg versus ICU. The dissemination of results is scheduled to take place in September of 2022 with the administration at CHA Everett Hospital. A meeting is scheduled with the ED nurse manager, ED nurse educator, and the chief of emergency medicine. At the meeting, I'm going to present this very PowerPoint presentation on this scholarly project. I'm hopeful that by sharing the results of the project with administration, it will prompt action toward creating and implementing an official sepsis response protocol within the department. The Doctor of Nursing Practice, DNP, is ultimately designed to produce leaders of nursing. Nurses that possess the highest level of nursing expertise and work either in a clinical setting or leadership role once they've obtained the required credentials. The DNP program has provided me with the knowledge and skills to influence healthcare outcomes through organizational leadership, health policy implementation, and direct patient care. This DNP project is my proof. That concludes this presentation. The completion of this project could not have been possible with my sole efforts. I would like to acknowledge those who have contributed to the development of this project and were most helpful in its success. Thank you to my scholarly chairperson, Dr. Tanya Crystal. Thank you for your consistent support and guidance throughout this project and doctoral degree. Your attentiveness and genuine passion to help me succeed allowed for a cohesive and professional paper and presentation that helps portray the hard work to successfully complete this project. I would like to thank the Everett Hospital's ED nurse manager, Maureen Franklin, and the ED nurse educator, Richard Durkee, for their excitement and support in implementing a sepsis response protocol in the department. Maureen and Richard often checked in on the progress of this project and offered support and inquired about the need for any additional resources. I kindly thank the Maryville University and Everett Hospital IRB teams for their diligent review and follow-up throughout the application process of the IRB. A special thank you goes out to the Everett Hospital ED staff for embracing the departmental change and consistently providing the safe quality care. And last but not least, thank all of you for attending my presentation this evening. Thanks for all the support, and if you have any questions at all or you'd like to discuss this topic further with me, please contact me at the email address provided here. I hope you have a wonderful rest of your evening. Thank you again.